So the CA patient motion, you're going to start them at about 45 degrees. Ideally, I like to try to get the leg. That's good. Can you show them, Cody?
What's that? Oh, so movement-wise, you're going to keep the leg nice and straight. The doc should be instructing you how to move the leg. I mean, but general movement's going to be hip flexion, adduction. You can add internal rotation to it as well. So you're dragging the leg along the table and listening to the treating provider's guidance.
So if I'm feeling very well, then yes, I'm going to tell Cody, flex the hip, adduct the hip, internal rotation, whatever, and you're paying attention to that. Okay, so I'm down here. Depending on where you're at, you might be a little bit behind, maybe even a little bit forward. The nerve is coming around like this, so we're maintaining our tension vector. My depth is going to be down that way. What I'm doing after I take depth is something that I'm working on a lot with nerve entrapments is I take my depth in and then I'm nudging in and behind the nerve. So I'm going in that way and then I'm just nudging up against it, because that nudging up against it will decrease the tension set distance. And then from there, if the PS is right here, a good rule of thumb is probably going to start the tension vector that way, but I'm going to tension clock whatever pulls the tightest. So notice my hand is like, this is very nicely seated and I'm comfortable with my hand like this. Pisiform over the thumbnail. I'm sinking in my depth, and then I'm trying to get into the corner on the anterior side of the nerve to get underneath it with the idea of lifting the nerve off of the deep external rotators. Then right here, notice where my elbow is. My elbow is perfectly aligned with my thumb, and I'm leaning with my sternum in the direction I think it's pulling tightest. So right here, I'm probably going towards like S2-ish, maybe S1.
So something also kind of just really cool to take note of here is how Dr. Chris's forearms are essentially perpendicular to each other, right? So if we're taking our depth 90 degrees into the tissue and then taking our tension parallel to it, your forearm should be pretty close to parallel, like, or 90 degrees to each other. So, and this is, as he's adjusting and moving around, his forearms are staying roughly 90 degrees to each other, which is cool to see.
I'm on a plank, I'm on my toes, and now I'm leaning with my right obliques and my abs in that direction, basically towards Chris. Go ahead, Cody. If you need to tell him pause, Cody. And then I move my feet, and then I make sure my tension's peaked out. Go ahead. And I'm just leaning. Now I'm going towards Jamie. I'm leaning. I didn't tell you anything, but you can feel better than probably I'm feeling right now.
So during the treatment pass, was your vector changing?
Yeah, I started towards Chris and I ended towards Jamie. Yeah. So I'm being slow. This hand is pretty damn soft. There's a little bit of contraction after I take my tension set. I'd rather you be really soft with this than be like this, because this is going to make it nearly impossible. If nothing else, even if you just take your depth and you're nudged up against the nerve and your assistant moves the leg, you'll feel slide and tension without taking the tension set. And I would argue that that is a more important step right now than treating adhesions and not feeling stuff. So you could just get in here, find a spot, take your depth. I might call it D1 and D2, I don't know. D1, and then D2 is I'm nudging down into it and behind it. And I could just sit here. Go ahead, Cody. I'm not applying tension, but there's slide right off the bat. I can feel which way it wants me to generate tension, and that's valuable. And it's a diagnostic pass. How much is it pulling tight? That's very valuable to do. Because if I can't do that, then it's going to be hard to actually treat stuff. But notice the box. This hand's soft, this hand's here, this forearm's my tension, this is my depth. I'm planked out. full plank, not 2% less plank. My hips are fully straight and out. I'm on my toes, and I'm going like this. I'm moving this way.
It's a weight shift with your body.
And so that's what's generating the tension, and that's what makes it easy. You can generate a lot of force without doing this and without making it hard for you to do lots of reps over the day. Most important part for all this stuff is feeling. The setup and stuff you need to keep working on, where to put your hands in your body, but we really want you to feel stuff. So feel a nerve that doesn't bow, feel slide, feel tension. This is the most important thing that will bring us the fastest, most long-term beneficial results as possible.
If you feel the nerve slide, that's a win. If you feel the nerve slide and you build up tension along with the nerve slide, it's a bigger win, right? If you feel the adhesion reduce, another win.
And, sorry, one more thing. Recheck it after one pass. Is it softer? The goal is you immediately recheck it and it's immediately softer. If we're not rechecking it, we're not holding ourselves accountable for what we're doing. So every single pass, you recheck it and then someone else can recheck it and find the next bad spot.
What happens if you check it and the tissue's like more hypertonic?
Then you irritated something.
Okay.
So it was the wrong spot, or the technique was off, or just a lot of tone or whatever. So some people had
or the tissue dose.
Tissue dose. Yeah, some people had irritated sciatic nerve. So that doesn't mean there's not going to be adhesion. We want to be mindful of dosage. Like John, we want to make sure that he's got that neuroma, so we want to unload it as much as possible. So if you're treating someone like John, just try to pay as much attention as possible, and not try to butt too much into that nerve to irritate, so we can't do the posterior thigh sciatic nerve stuff.